Dr. Spellberg is starting off his week actually with us to discuss a different perspective of discussion that really deviates from our general discussion, as I was saying to you, Dr. Spellberg, when we got on, whereas we are mostly discussing clinical and public health implications, intervention strategies, suggestions, guidelines, everything on those topics surrounding COVID. We want to talk today a little bit of its influence on the infectious disease healthcare infrastructure in the U.S. and what a pandemic has kind of done to expose lights in some cracks. And honestly, you can speak to it in multitudes better than I could. So I just want to kick it off to you and ask you what exactly, I guess, what has that exposure looked like to you, and how do we need to start addressing it?
Well, I mean, there's been multiple ways COVID-19 has sort of stripped the veneer away from U.S. healthcare and exposed the rot within. And many of these ways are sort of detailed in the book Broken, Bankrupt, and Dying, which got published in June. The first is that we're the only country in the world that links healthcare access to employment. And that becomes increasingly obviously stupid in a global pandemic that's causing massive unemployment, so that at the very time people most need their healthcare access to limit the spread of the virus and take care of themselves, they can't get it because they're not employed anymore. This is absurd. I think we also can speak to the fact that we don't have enough ID specialists in the United States to handle public health crises and global pandemics, because our specialty is not aligned with the predominant market forces of a fee-for-service health system, which the US remains and most other healthcare systems do not.
Right, and exactly looking, maybe if we just start at the latter discussion point of staffing and available personnel. Obviously, that was the way that conversation manifested for us back at the first start of it. And I think I even talked to some of your peers and colleagues out in Southern California, I think at UCLA, discussing exactly strategies for allocating appropriate staffing elsewhere to resolve it. It was very troubling to hear, and of course we were talking about emergent care at the time. It was very troubling to hear that overall the availability just wasn't as good as we'd hope it to be for qualified individuals to address it. Obviously, if we're talking about it being a systemic issue, it stems all the way down to education and, I guess, exclusivity of receiving an education and medical school and all the factors that play into someone pursuing a career in this space, right?
For many years, ID fellowships have not filled all over the country. The candidates that we get are often not at the top of their class. Medical school costs to students have dramatically risen in the last 20 to 30 years. The average amount of debt has skyrocketed, and ID specialists are one of two medicine subspecialties that make less money than hospitalists. Begging the question, why should top talent choose to spend extra years in training to make less money? We are a cognitive-based specialty, and the fee-for-service health system in the United States does not favor cognitive specialties and will not, because it is not aligned with the market forces of how money is made in healthcare. I'm the CMO of the hospital, and I'm an ID doc. And when ID people come to me and say, can't you raise my pay? The answer is no. How am I going to do that, right? Hospitals and health systems, their operating margin dependent on procedural-based specialties. That's the way our healthcare system is set up. It wasn't intelligently set up that way. It accidentally came into being, frankly, as a side effect of efforts to combat World War II post-war inflation. Nobody ever rationally sat down and designed our healthcare system. So we can lobby all we want to raise E&M billing at the Medicare RVU committee, the RUC, or we can do what ACP has done and start advocating for true healthcare reform. If you want to tweak, you'll continue to get the crumbs left over at the table of healthcare. If you want transformation so that, Mohs plastic surgeons aren't making $1 million a year, while ID docs are making less than general internists, then you need fundamental healthcare reform.